the nurses play a major role in all this, especially to improve patient care and cut costs and everything, right?
They certainly do.
Okay.
So that was perfect introduction for what I wanted to talk about, which is really what the nursing profession can expect with these changes and what the public can expect from the nursing profession with these changes. With the expansion of the insurance, it's clear that we don't have enough primary care providers, and so we will need more primary care providers, and that's going to be physicians, that's going to be physician's assistants, and it's going to be nurse practitioners. And as nurses, we're going to need, there's been 50 years of research on nurse practitioners, and they provide high-quality care that's safe and less expensive. We need to continue to educate the nurse practitioners. We need to make sure that the nursing schools are gearing up to do that, and we need to make sure that we're working in the appropriate interdisciplinary teams. There are some, even in this time, which is quite friendly for nurse practitioners, there are scope of practice issues that differ state to state. And as a profession, and hopefully we can get some of this sorted out, but nurse practitioners in some states, they can prescribe, some places they can prescribe some drugs, some other, it's very different state to state. There's also differences based on the organization where they work on, and some of that's historical, and there's just some organizational barriers, and we need to have the sort of right environment so everybody can work at their full scope of practice. And I really believe that we are at a time when that will happen. So that's sort of exciting for nurses. And as consumers, I think you'll be seeing more nurse practitioners in your primary, in your interdisciplinary teams that you're going to, or just even going to nurse practitioners. I think you can expect to see that. With the change in quality, whether it's bundled payments or the hospital value-based purchasing or the readmissions reduction program, I think this is going to affect nurses quite a bit that are working in these institutions, because often they're the ones that are collecting a lot of these measures. Some of the measures come from claims data, others come from nurses collecting the data. And another important measure that we're moving to is to really think about how the patient perceives the care. So I'm very happy to see that an important measure within the hospital, not only is it what we call these patient safety indicators, which are based on claims data, which are rare events that don't happen, and I don't think a lot of things are going to we're going to see a lot with these patient safety indicators, but we're also using HCAHPS, which is the satisfaction scores. And within the HCAHPS, some of the things that we have seen that really are important indicators are multi-dimensional satisfaction scores, but how responsive were the hospital staff? How was communication with your nurses, and how was communication with your doctors? And it's that communication with the nurses and responsiveness of staff, which is very indicative of overall patient satisfaction. So nurses are going to be pressured to make sure that they're providing that care, as we should be. And you can expect that people, if you're in a hospital or somebody that you know is in a hospital, that they might very well get a satisfaction score that they're supposed to be filling out later. The unintended consequences of, the overall goal of this measurement is really good. It's to have facilities improve care with important outcomes. A potential unintended consequence with some of these mandatory reportings, with some things and some of these metrics, is that it focuses a facility on the measurement and not on their local issue. And hopefully that won't happen, and hopefully we'll still find ways to provide the quality of care. But there's a lot, and some people say, well, heck, we won't, we'll have to hire more people to do these measurements, and we're going to have to lower staff, and you hear about all these horrible scenarios, but I don't think that'll happen. Specifically with the big focus on readmissions reductions, in October of 2013, Medicare beneficiaries will they won't be paying for readmissions of heart failure, pneumonia, and acute myocardial infarction. And in 2015, that's going to expand to even more services. I think that that's very important for nursing, because nursing sort of provides is the provider that coordinates care. And there's been a lot of research about transitions of care and how to help often vulnerable patients go across these transitions. And I think we need new innovative models. We need to be using the models that we have good research about that promote having somebody providing that transition that's in the hospital and works with the interdisciplinary team in the hospital and provides the care outside. We have to do a better job at those transitions. Otherwise, people are getting sent home with a list about what medications they're supposed to be taking. They go to their primary care doctor or their nurse practitioner. They don't have the list. Things get changed, and they're back in the hospital. So we've got to spend a lot more time on the transitions, and we can do a better job. And I think I'll stop.
Okay, that's great. Pat, thanks so much.